and welcome to All About Us Radio, where we're empowering women. Tonight, I have an amazing guest speaker by the name of Dr. Grace Ford. She is the Director of Neurological Services at North American Partners in Pain Management here in Lake Success, New York. Previously, Dr. Ford was the Director of the Headache Clinic at North Shore University Hospital, which is part of the Northwell Health System. Dr. Ford is a member of the American Academy of Neurology, the American Pain Society, the International Association for the Study of Pain, the Long Island Headache Society, and the American Association for the Studies of Headaches, and the International Headache Society. She has done numerous research and published several papers. She continues to get involved with teaching and involved with a number of different programs that circulate around the dedication and the management of chronic neurologic and neuropathic pain, migraines, and pain management. Dr. Ford is board certified in neurology and pain management. She has written, as I said, numerous papers and co-authored several chapters in textbooks. It is my pleasure to introduce Dr. Grace Ford this evening, who received her medical degree from the Albert Einstein College of Medicine in the Bronx, did a residency in neurology at the University of California, San Diego, and also did a fellowship in pain management at the University of California, San Francisco. So with further ado, I want to introduce Dr. Grace Ford.
Thank you.
Dr. Ford,
Thank you, Dr. Jones.
it's a pleasure to have you here with us tonight. Welcome.
Thanks for the invitation. I'm thrilled to be here.
Well, as I introduce our audience, some of your accolades and a numerous one of your accolades, let's talk about neurology and issues that affect women. What are some of the neurological issues that affect women?
Some of the more common neurological issues that affect women, I would say the number one are headaches, migraines in particular. Women are three times more common to have migraines, three times more common than men. Multiple sclerosis also affects women disproportionately, as is fibromyalgia and chronic fatigue syndrome, which is a diffuse musculoskeletal pain, fibromyalgia, and chronic fatigue syndrome. Epilepsy is also another condition that affects women more commonly, as is Alzheimer's disease, Parkinson's disease, and strokes. Especially in the African American community, strokes is something that affects women in quite alarming numbers.
Wow. So let's talk about headaches. Let's talk about migraines. Migraines can start at any age. What are some of the signs and symptoms that women should look for them to think they have migraines, that they should see a neurologist?
Well, starting from childhood, something that a lot of people really are not aware of, that children who get car sickness usually will go on to have migraines, and car sickness is a form of migraines in children. So if you have a child who is always car sick, you can almost tell that that child has migraines. Sometimes it's too early to tell depending on the age of the child. But in terms of the symptoms of headaches, and migraines is not just a headache. Patients have headaches that are throbbing, that are pounding. It could be one side or the other. Most of the times, patients cannot function. So the light bothers you, noise bothers you, smell bothers you. There is even a condition we call allodynia, where patients tell me, Doc, my hair hurts. And you ask, how can your hair hurts? But they have that super sensitivity of the entire head and neck area. Like you have an intense sunburn and then you come and hit someone. That is what it feels like. It's difficult to wear your glasses. Nowadays it's difficult to wear a mask or anything like that. So those are some of the symptoms patients get, along with nausea and vomiting in patients. About 15% of patients have a warning that they will get a headache before one starts, which is called an aura. And the aura is usually visual. So they have problems maybe with loss of vision in one half of their field, the kaleidoscope type symptoms, or an Alice in Wonderland symptoms we call metaphorpsia, where things seems distorted.
Mm.
These are all symptoms that people can get, or sometimes they might smell something foul, like burning rubber, 15, 20, 30 minutes before you have a headache. So these are all symptoms that our patients should look, should pay attention to. Another interesting thing, though, I must say, is that even 24 to 48 hours before the headaches even start, patients have a lot of cravings, and they have cravings for things like sweets. And if you're really in tune with your body, you can tell that 24 to 48 hours later, I will come down with a headache. So these are some of the things that people need: yawning, excessive thirst. Sometimes people get very irritable. And these are all warning symptoms of what's to come 24 to 48 hours later.
And it's important to know that sometimes it may be hormonally related to their period cycle as well.
It absolutely is.
So when do you think a patient should come and seek care with somebody like yourself?
The patient should come and seek care but with someone like myself. If you're having maybe 4 headaches, severe headaches a month, and you take over-the-counter medication such as acetaminophen or a non-steroidal, and if it does not work, then you need to seek care from someone who specializes in treating headaches. Also, if you have a warning, like the symptoms I mentioned, the visual symptoms, that is lasting like 60 minutes or more, that is also a harbinger of potential stroke. So if you're a young woman, the aura is lasting a long time, you may be on oral contraceptives, and if you're throwing the risk factor of being a smoker, then you definitely need to come and see someone like myself, and some of those habits will need to be modified.
Understood. So then you mentioned something as well about fibromyalgia. Can you explain to the audience what fibromyalgia is?
Fibromyalgia is a diffuse body pain, musculoskeletal pain. Your joints hurt, your muscles hurt above and below the waist and on both sides of your body. So it's a diffuse musculoskeletal pain. We have specific tests in terms of like the examination. So there's no MRI scan or CAT scan you can do to, determine whether someone has fibromyalgia or not. It is a clinical diagnosis. But in addition to the diffuse pain that patients have, they also have a lot of fatigue with it. Patients also have what they call fibrofog, meaning that they have difficulty with concentration and memory. And that is part and parcel of the whole syndrome. And it is more common, as I said, way more common in women than it is in men.
Interesting. How you said there are different ways to make the diagnosis. Are there anything that may trigger it? Any kind of relation to food, any kind of comorbidities, anything of that sort that may trigger or put somebody at risk for fibromyalgia?
It's interesting because fibromyalgia, we haven't really determined that, but sometimes people have like a chronic viral syndrome, like with CMV, or something that might cause mononucleosis, something like that. Sometimes when patients have those type of viral illnesses, they usually end up with this diffuse musculoskeletal pain. I have to admit, now in the age of our SARS-CoV-2, we've seen a lot of patients who've had it who end up with this diffuse musculoskeletal pain that has persisted now for several months.
Interesting. So let's talk a little bit about some of the headaches and a little bit of memory loss. As you brought up, COVID is here to stay at this rate, right? Not that we're happy about it.
Unfortunately,
We were hoping it was going to go away, but we're getting so many mutations and variants about it.
right.
I'm finding some people finding some degree of memory loss as they're going through some of the changes of when they contract COVID, that their memory for that during that time and as COVID is resolving is not always the same. Any thoughts on that, Dr. Ford?
That is something that I've seen a lot of people have a lot of difficulty with concentration and memory. And also, and this has persisted. Again, it almost seems like there's some sort of fog. But in terms of memory problems, I don't think that this is a form of Alzheimer's disease. Now, there are dementia. the general term dementia is a loss of cognitive functioning, problems with thinking, remembering things, reasoning. So that is the whole, and it interferes with the activities of daily living. But there are five different types of dementia. So there's Alzheimer's disease, which is what most people think about. There is dementia that is related to a form of Parkinson's disease. There is something we call vascular dementia that we see in patients with strokes, with small strokes. And I think the memory problems that people are complaining of in terms of with SARS-CoV-2 is more of the vascular type, more so than Alzheimer's type. There's also something called frontotemporal dementia, which is what the name implies. So the frontal lobes and the temporal lobes, there's atrophy, and these patients have a lot of behavioral problems. There is also something called mixed dementia, where you have both Alzheimer's disease as well as vascular dementia. And vascular dementia is more common in African Americans because we have a higher incidence of hypertension, and hypertension is a cause of many strokes. And so we are more at risk for getting, and women in particular, are more at risk for getting vascular dementia. So you can have a mini stroke and you just lose a little bit of brain function. You never quite get back to where you were. A second stroke, you lose a little bit more, and it's just a slow progressive decline.
So you mentioned mini strokes, Dr. Ford. What exactly is the difference between a mini stroke? Some people may say, oh, I had a little slight stroke, mini strokes. It's synonymous with TIA,
That's correct.
transient
A
ischemic
TIA is
attack.
a transient ischemic attack. So someone
What's
might
the
have
difference
a
between that and a full-blown stroke?
So a TIA, you might have a TIA now, and then you have numbness or weakness in an arm or leg or difficulty with speech, and it resolves within 24 to 48 hours. Whereas if you have a stroke, the bigger vessels are more involved, the MCA, and you have more deficits than you do with a TIA. So you might have paralysis of an arm or a leg or both, or the face, or depending on which side of the brain is affected, you can have problems with difficulty with speech, problems with concentration, memory, or even behavioral problems. If you have a brain that if you have a stroke that affect the right side of the brain, that is involved with a lot of difficulty with behavior. A stroke that affects the left side of the brain, that would affect the right side of the body, and that would also affect speech. So it depends on where the problems. If you have a stroke in the back of the brain, in the occipital region, that can affect your vision. So it depends on where the brain is. But to make matters simple, the stroke is something where you have more deficits, more permanent, long lasting, more severe deficits versus a TIA where symptoms tend to resolve.
So if somebody has a TIA and they come and see Dr. Ford, what would be some of the things you would tell the patient?
Well, I would look for risk factors. So, does the person have diabetes? Does the person have high blood pressure? Does the person have what we call a hypercoagulable state? So, if it's a young person stroking a young, then you need to do a workup. You ask are they on oral contraceptives? That's very important. Or if it's an older person, you want to know, well, is there risk factors for cancer? Why are they having a hypercoagulable state? Excuse me. Excuse me. And these are all the things that you would work up for. I would also, so in addition to blood work, I would also do maybe carotid ultrasound to see if there's any problems with the blood vessels. An MRI, excuse me, an MRI scan of the brain to see if there's any problems with
What
the
we're going to do is we'll take a quick little break and come back.
brain. Thank you. I'm okay now.
You sure?
Yes, I'm good. I don't know what
Okay.
happened there.
Okay.
I'm sorry about that. So
That's okay.
we definitely need to do a workup, a detailed physical exam, and MRI scan of the brain to see what's going on in blood work. Smoking, you want to ask about that. Is the patient a smoker? If they are, of course, that has to stop. Not easy, but that is some of the things that we ask.
Okay. And is there medication that somebody can use or utilize to prevent having a stroke?
You know, when I was a neurology resident, one of the things that they taught us, unless you have a contraindication, anyone about 40 years of age or older, if you can, you should take a baby aspirin maybe once a week, unless there's contraindications. A baby aspirin, what it does is it works against the platelets, and the effects can last up to 7 days. So one does not necessarily have to take a baby aspirin every single day. I have on my phone an alarm every Sunday. I take a baby aspirin, my husband and I, again, as a stroke prevention. So that is one of the things that folks can do so that you can make the blood more fluid, if you will, is take a, and it doesn't have to be a full strength aspirin. A baby aspirin works just as well.
Okay.
And again, lifestyle changes. Again, you have to look at diet, you have to exercise. These are all things that are critical in terms of maintaining general health. It's the same thing for the brain.
Got it. So another thing that you mentioned was multiple sclerosis. What is that, and how does it affect women? Because they seem to be more prone than men for multiple
Right.
sclerosis.
Multiple sclerosis is more common in women, and unfortunately, it occurs usually in their 40s when women have kids to take care of, they have jobs and everything else. One of the first symptoms of multiple sclerosis is vision loss, optic neuritis. And the patient can have an episode of optic neuritis, vision loss in one eye, and it can last 24 hours, go away, and that's it. 5, 10 years can go by and nothing else happens. And then they might get another symptom of maybe numbness in one arm or one leg, or difficulty walking, difficulty with what we call scanning speech. The speech is not fluid. Problems with the bowels and bladder. They have problems what we call a neurogenic bladder, difficulty urinating. And so all these symptoms can happen. And so there are different types of MS. There is the clinically isolated type, which you might have one episode of vision loss in your early 20s and then you never have anything else. The more common is what we call relapsing remitting, which means that you have episodes ever so often. Stress is a big trigger for multiple sclerosis. There is also the primary progressive. You have a symptom that starts and it just progresses. You never get a remitting stage. And then there's also called the secondary progressive, where you have relapsing or remitting, and that's how it started out, and then you transition to a progressive stage. And there's also called a rapidly progressive stage, where you start with symptoms and it just gallop along to the point where someone is wheelchair bound in a matter of months to a year. So there's a different stages. When we see patients with multiple sclerosis, we always ask where you were born, where you were raised. It has to do sometimes with latitudes in terms of the more northern latitudes versus more southern hemisphere. But and
So,
also if
Dr.
you,
Ford, not to cut you off, just to elaborate a little bit more on the hemisphere and the latitude and longitude, can you just give a little example of what that means, where people are from?
people usually Scandinavian people and people of that type of background tend to have more high incidence of multiple sclerosis than people of African descent. It is we do have people of African descent with multiple sclerosis, but it is not as common in our population as it is in the Caucasian population.
Understood. Okay. And the question regarding, you gave a large breakdown of different criterias and different types of multiple sclerosis. In when the person gets that blindness or may get that blindness, how, is it both eyes, the transient blindness? May it be one? Is it partial?
That's
Is
a that's an excellent question because in multiple sclerosis, it's usually one eye or the other. There's a condition called Devick's disease, and Devick's disease is also called neuromyelitis optica, and it's a mimic of multiple sclerosis. But the difference between Devick's disease and multiple sclerosis is with Devick's disease, when you have the vision loss, is both eyes that are affected, not one eye. And multiple sclerosis is more or less a degenerative disease. We get plaques in the brain, and the more plaques you get, is the more symptoms you have and the more deficits you get. Whereas with Devick's disease, it tends not to be progressive. The patients have an episode And usually that is what it is. It affects both eyes and it also affects the spinal cord. But again, so that is usually the distinction between Devick's disease and multiple sclerosis. Both eyes is Devick's, one eye at a time is usually MS, multiple sclerosis.
So interesting. I would think as a young person, if I ended up with any kind of vision disturbance or vision loss, I wouldn't necessarily think to go to the neurologist first. I would think to go to the ophthalmologist first, right? How many times would you say people end up at the ophthalmologist and multiple sclerosis may not be diagnosed or picked up correctly?
100% of the times. And that is the reason why we very rarely see patients with optic neuritis. We usually get that from the history. So when someone come to me because now my right arm is numb and my leg is numb and I'm dragging it and it's weak, and I would ask, have you ever had an episode of vision loss? Oh yeah, I did, about 5, 10 years ago. And that is how that comes out because it usually resolved. We never, you never say never, but we very rarely diagnose someone with MS if they have optic neuritis because you're right, they never come to us. There's no reason to come to us with that.
I think it's very important that we bring this out on a show like this because it's something to maybe say, hey, let me make an appointment both with a neurologist and the ophthalmologist so that
Absolutely.
it could be something that's addressed a lot earlier.
Absolutely. And there's also a specialty called neuro-ophthalmology, which is even the ideal person because if you see that person, they will also be thinking of multiple sclerosis because they're also neurologists with a subspecialty in ophthalmology.
Understood. We're going to take just a short break and be back with a lot more to come on neurology in women.
Throw and Tuck. It's handmade by myself, and you only can get it here, and it's patent, and it's only here at Rococo Design. It's like a regular pillow, or you can take the blanket out like so, fluff up the pillow, open up your blanket, wrap it around yourself, and then you can lay on your sofa and relax with your pillow throw and tuck. When you're done with it, just flip it over. When you don't want the blanket anymore, you just fold it over twice. Fold it over twice again. Fold it over. And tuck it in the back. And there you go. You're back to the pillow throw and tuck. Rococo Design.
All right. Welcome back, Dr. Ford. We left off by talking about different ways of treating multiple sclerosis and diagnosing it. So you mentioned dementia a little earlier as the start of memory loss, and then talked about other things like Alzheimer's and Parkinson's. Let's talk about early dementia. What does that actually mean?
When people say early dementia, usually what they mean is early onset Alzheimer's disease. It is not it is not 100% that as you get older you would lose your memory. That's something that we believed before, that it just goes along with age, and that is not true. People with early dementia, you notice it yourself, and it's very upsetting because you realize your memory is starting to fail. So you realize you might have some word finding problems. You can remember things from 20 years ago, 30 years ago, but what you had for breakfast is like, gee, I don't even remember. You can't find your keys. And things in the here and now becomes difficult. And you notice it yourself. And because it is very, what I like to call ego dystonic, is very upsetting to you, people then get very aggressive and angry because they really don't know how to express it. And then family members start recognizing it. And once that happens, then that is where it is. But the fact that once you realize your memory starting to fail, it is not a good feeling. But that is what early on, usually memory here and now, but memories from things that happened, many, many years ago is crystal clear.
Is there anything that can trigger early onset Alzheimer's or early onset dementia? Things like, say, if somebody was asthmatic and not oxygenating well, how about something like COVID where they weren't oxygenating and breathing well? Anything like that that can trigger
There,
early
there-
onset?
there's one of the major things that can trigger dementia and memory problems is repeated head trauma and concussion. And we see that with traumatic brain injury patients. So that is one of the things that one needs to definitely avoid. Um, People who have a lot of stress and depression can seem like they have dementia because they always complain of problems with memory. But we do something called a neuropsychological testing, which is a pen and paper test that can take many hours depending on how severe the memory problem is. And that would tell us if this is an organic problem or if this is non organic, meaning if it's truly a problem with the brain or if this person have too much on their plate, as we would say back in the West Indies, because they just have too much going on and they can't keep all these balls in the air juggling, as so many of us women tend to do. So usually that is the case. But in terms of, there's some people were saying that the fillings in your teeth, silver fillings that they used to use back in the day, maybe there's a link with MS, maybe there's a link with dementia, but all these things haven't really been borne out, so we really don't know. And but what one of the key things that they tell you to do is definitely is to use your brain. Of the old adage, if you don't use it, you would lose it. So you really want to, I mean, everybody do the crossword puzzle. You want to take a different way to work sometimes. You want to do things differently and not just the same route so that you can make many different connections. And educated people tend to, it's not like they get less dementia, but they can cope and they can manage and they can compensate is more the word, more if you have more connections than someone who is not highly educated. So again, doing crossword puzzles, number puzzles, just learning a new task, knitting, whatever. Forming new connections in the brain is very helpful in delaying, if you will, Alzheimer's disease.
Okay. But what is the difference between Alzheimer's disease and Parkinson's disease? Because there's
Parkinson's
still
is
both forms of dementia associated with it, but one seems to have more of physical aspects of it with shaking and imbalance. So, what's really the difference? Why is there a trigger or a fine line difference?
So with Alzheimer's disease in the brain, you have something we call plaques and tangles, and you see that, but you can only see that on autopsy. Unfortunately, you cannot see that when the person is living. Parkinson's disease is a disease that affects a part of the brain called the substantia nigra, which is more involved in motor function, so in movement. So patients with Parkinson's disease, they're very slow. They have what we call a mask face, so which means that they have very limited or no expression. Their handwriting tends to get very small, so you can barely read it. The patients have this what we call a shuffling gait. When they're walking, most of us, when we're walking, we're swinging our arms. When you have Parkinson's disease, there's no arm swing. And there is also a lot of freezing. So patients are walking and they just stop and they just can't get going. And interestingly enough, if you just put a ruler down or a line in front of them, then they can step over that line and keep moving. So patients with Parkinson's disease, they also have something called Lewy body disease. And the Lewy body disease is what affects the brain. And so they get a form of dementia. Now, I said you also have Lewy body with Alzheimer's disease. But with Parkinson's disease, you also have a form of Lewy body, and those patients get memory problems or dementia related to their Parkinson's disease. Now, not all Parkinson's patients have Lewy body dementia, but all Lewy body dementia patients have Parkinson's disease.
Is there any relation or crossover with hallucinations that lead to any kind of psychological components?
Patients with both Alzheimer's disease and Lewy body dementia have hallucinations. But patients who have like schizophrenia, for instance, they're not at a higher risk of getting one or the other. But there is a lot of hallucinations and delusions with patients with dementia, especially in the later stages of dementia.
Is there anything that could be done, medication that could be given to maybe try and slow down the progression of whether it be Alzheimer's or Parkinson's to at least try and also help with the memory loss? Or that's question one. And the second part of the question is anything that could be given to help with if there is any kind of hallucinations or psychological abnormalities that may be related to both diseases.
Well, in terms of like Alzheimer's disease, so it's important to get diagnosed early. When patients get diagnosed early, there are a lot of different medications that can be given to slow the progression. At this point in our level of knowledge, we cannot cure, we don't have any cure right now for either Alzheimer's disease or Parkinson's disease, but we can slow the progression of the dementia and give patients more productive years in terms of their memory, in terms of Alzheimer's disease. So there are different medications for both. You can start off. The second part of the question was in terms of, I'm sorry.
The second part of the question was, is there any medication to help with the hallucination
Yes.
factors?
In terms of the hallucinations, the same medications that we use to treat hallucinations in patients with schizophrenia is the same medications we would use to treat patients with delusions and hallucinations from both Parkinson's disease, Lewy body variant, and from Alzheimer's disease. Those same medications we would use.
Is there any genetic components? Those are some of the things that I know patients are always concerned about. My family may have had this, am I at risk of getting this?
Yes, there's genetic components for both. For Alzheimer's disease, there is a genetic component, and especially if you have a parent or grandparent who started having memory problems very early on, meaning like in their 40s or 50s, there is a very, very high genetic correlation. And there's blood tests that one can do, genetic testing. I'm not sure if you want to know if you have the gene or not when you're early, to see if you can, if you have one copy of the gene, chances are about 50%. If you have both copies of the gene, the numbers shoot up to like 90+%. Do you want to know that? Some people do, some people don't, depending on your makeup. Parkinson's disease, there is also a genetic component to it with Parkinson's disease. And again, in both conditions, the earlier the onset of symptoms in the index case means that their offsprings have a higher incidence of contracting one or the other.
So, I guess maybe one of the important things you said, if you could diagnose it early, you can try and get on some medication to slow the progression of it. So it's a good possibility that maybe you may not want to know that you're at risk for it if your family member has it, but yet it's important to maybe consider doing it to try and slow the progression. I guess if you're starting to do word searching or a little bit of forgetting, to see if that, be a factor.
Absolutely. And I see patients with Alzheimer's disease, and I would give them the medication, and the family members would come back and say, you know what, I see an improvement. And even the patient would tell me, yes, I'm thinking a little bit more clearly. I'm remembering a little bit more. And if you can get an extra 2 years where you in that stage, it's worth a lot.
Good. Does nutrition and diet play a factor in decreasing any of these neurological issues like Alzheimer's or Parkinson's?
It does. It definitely does. Good nutrition is very important. You have to feed the brain, if you will. So good nutrition plays a role in migraines, for instance. There are a lot of triggers for migraines. Caffeine is one, in particular, MSG is another one, that's triggers for migraines. And so people need to do things in moderation, everything in moderation. And so things that protect the brain are things like fatty fish, so things that are high in omega 3, sardines, salmon, if you like things like that. Dark colored berries, the blueberries, the blackberries, and things like that. Those are all things that are high in antioxidants, and they protect the brain against, to be honest with you, MS, Parkinson's, Alzheimer's disease, definitely migraines. There are certain spices. I'm from a West Indian background, and we use a lot of turmeric and curcumin. Curcumin or cumin is the active ingredient in turmeric, which is a potent anti-inflammatory agent. And we believe there's a certain amount of inflammation associated with both Alzheimer's disease and migraines. And so you can get them in pill form, but it's also more fun to cook with these herbs. Dark chocolate is also good because it's high in antioxidants, as is nuts, which is high in vitamin E. And we believe that it helps decrease mental decline, the vitamin E. So that is helpful. Caffeine, as I said, in moderation, because it's while caffeine can help with certain headaches, it can also cause headaches. Broccoli is very good in antioxidants. So there's a lot of different foods that one can do. Pumpkin seed, something that one wouldn't normally think about. And certain ions like magnesium, zinc, copper, vitamin C. These are all things that are good for the brain. And they protect against what we call free radicals. They scavenge free radicals, and so protect against the formation of plaques and tangles, which can, which we find in Alzheimer's disease. So there's a lot of things that we can do. Sleep hygiene. It is very important to get an adequate amount and good quality sleep. So not just you in bed for 8 hours, but you want good quality sleep, because that also makes a big difference. Exercise. You have to move. Exercise doesn't mean you have to go to the gym and lift 100-pound weights for 6 hours or whatever. Exercise, you do it for 15, 20 minutes a day. You get moving, get the blood flowing, if you will. Stress management, extremely, extremely important for just about any medical condition that I can think about. Substance use, again, tobacco. If patients are smoking, we need to get them to stop smoking. There's always the issue of wine, and red wine in particular. Red wine is good in terms of with the antioxidants and everything else. But again, one glass of red wine is something versus having 3 and 4 glasses of red wine a day. So again, in moderation. So these are all things that one can do to help with their brain health in terms
Man,
of food and diet, exercise.
so now that marijuana has become legal, have you seen any changes from a neurological standpoint due to more increase in cannabis use?
The thing about cannabis use is I'm a big proponent of cannabis use, but I am not a proponent of cannabis use in, I would say, individuals beyond. If I'm very conservative, I would say age 26, but if I'm being realistic, beyond younger than age 21, because younger than age 21, the frontal lobes are still forming. And so I am not a big proponent, unless it's pure CBD that is used to treat epilepsy. I am not a proponent of cannabis in folks younger than the age of 21, because it can alter brain function. It's also interesting because schizophrenia is more common in males around the age of 19, 20, 21 is when it usually starts, when it's first diagnosed, I should say. And it's also that age group that use a lot of cannabis in terms of male. But so I see people who smoke too much can have problems with concentration and memory, absolutely. Again, in moderation, it can help. believe it or not, with Alzheimer's disease. It definitely can help with the freezing and the tremors that we see in Parkinson's disease. It is something that I prescribe for that. But again, you have to use it in moderation.
So you mentioned marijuana and you mentioned CBD. Can you explain to the audience, for some of them that don't know the difference, what is the difference?
The marijuana plant or the cannabis plant has over 580 different chemicals in it. A lot of people are not aware of that because when you think of marijuana, they only think of one chemical, that is THC. THC is one of the 580 plus chemicals. The plant itself have a lot of different CBD part of the CBD. So the THC is what gets you high. The CBD part of the plant does not get you high. So in cannabis or marijuana, it has THC, CBD, and a lot of other different compounds. CBD that you get over the counter at CVS, 7-Eleven, or Amazon, or wherever you get it, that is more hemp based. Is a hemp based product. So the amount of THC that it has to be less than 3%. So CBD or hemp is legal. It was made legal through, I believe it was a farm bill, but cannabis or marijuana is illegal still in the United States, federal on the federal level, although it is legal both medicinally and recreationally in over 37 states. Yeah.
All right. So if we think about the one thing we didn't really touch on, and I wanted to kind of leave for last, was seizures, epilepsy. There are different types of seizures. Can you tell us the two different types or the types of seizures that there are, and how can we go about treating them, and what should one look for?
So there are different types of seizures. So there's grand mal seizure, which is everybody thinks about, is a seizure where someone is convulsing on the floor, maybe biting their tongue, eyes rolled back in the back of their head, and that is something that is very visible that one can see. And head trauma, of course, can cause that. There is something called seizure in the elderly, where patients who are in their 70s and 80s for the first time just start having seizures. But it usually starts in younger individuals. There's febrile seizures that we see in children, usually 18 months or less. And when they get very high fevers, they get seizures. And that is something that needs to be taken seriously and treated aggressively. But the generalized tonic-clonic seizures we see, and of course there are treatments for that. As I said, cannabis is one of the very effective treatments actually for the treatment of seizures. But there is also another seizure called petit mal or absence seizures. And we see that in children, they call it almost daydreaming, not almost, they call it daydreaming. So you might have a child or someone, you're talking to them and they're talking to you, and then all of a sudden the child or the adult is just like staring into space, and like the lights are on but no one is home. And then afterwards they come back and they will pick up the conversation, but they're a little bit confused, not quite all there. They never fall, they never lose consciousness, because it is affecting one part of the brain. When you lose consciousness, is that the connections to left and right brain is affected, and that's why someone fall and lose consciousness. But when you have petit mal seizures or absence seizures, it's usually focal areas of the brain that is affected, so patients don't fall down completely, but they are just not there with you. Patients can also have a seizure where just one hand is shaking or one leg is shaking, and they have altered mental status, but again, they're not as quite as confused or out of it as someone who has a petit mal seizure or grand mal seizure.
Interesting. So, how do we then get patients to get to you, the neurologist, to have a workup? Say that kid that zones out. How do we get the pediatrician to make that referral? How do we get the moms or the caretakers to, what should they notice?
Anytime you see a child that is sitting, sometimes staring into space, and you say, oh, he's a daydreamer, or she's a daydreamer, you want to definitely get that child to the pediatric neurologist. we need to do an EEG, which is a brainwave test, to see if the child is having seizures. And or sometimes kids have what we call nocturnal seizures. They might be wetting their bed. And if the child is already potty trained and they're wetting their bed at night, seizures is one of the things one want to consider. Or if the child wake up and they have a sore tongue, it seems like they bit their tongue during the nighttime. That is a child that you want to get to a neurologist so that you can work it up, because seizures is still a lot of people still die from what we call status epilepticus. I just had a patient not too long ago who died actually from seizures. I wasn't treating the seizures myself. She had another epileptologist. But again, there's still people dying in this day and age from seizures. So, and sometimes what happens with children who have absence seizures or petit mal seizures, as they get older, sometimes that can transition to a grand mal seizure. So you do want to get patients treated early on. And there's a phenomenon called kindling. And it's like money begets money, seizures beget seizures. And if you allow the brain to continue to seize and continue to have those neurons firing off repeatedly, then the brain gets into that mode and then seizures get worse and worse. It's something called kindling. So you try to avoid that by giving appropriate medications to quiet down those neurons so they're not continuously firing off and causing seizures.
All right, we touched on a number of different neurological issues today. So, if we could tell the audience a few takeaways from each of some of the topics that we discussed, for instance, migraines, for fibromyalgias, for multiple sclerosis, dementia, Alzheimer's, Parkinson's, and seizures, what would be, just give the audience some important takeaways for each one of them?
So, in terms of headaches, some important takeaways is that if you never had headaches before and you're 50 years of age of old and you had the first headache in your life, run to the doctor. That is not a migraine. Maybe you're having an aneurysm. So that is something you definitely need to take care of. That is something that is a medical emergency. So that is definitely a take home you want for migraines. In terms of, and it's also limit your caffeine intake. That is another take home. In terms of multiple sclerosis, if you have, vision loss that happen, maybe if it lasts for an hour, even 2 hours, you definitely want to see both, as you said before, the ophthalmologist and the neurologist, so that you can be evaluated for possible multiple sclerosis. That is a definite take. Or if you're someone who, when it's very severe heat and humidity, you get like weak and you just can't function, something like that, you want to also get that evaluated by a neurologist. In terms of like patients with fibromyalgia, if you just have problems where you're just chronically fatigued, one of the things that you want to also check is vitamin D as in David levels. A lot of us, the dermatologist has been very good at telling us to keep out of the sun. And so a lot of us, especially those of us with darker skin pigments, we don't absorb the rays as well. So we do need to spend a little bit more time out getting that vitamin D if you're not replacing it via the pills. So vitamin D is also, low vitamin D levels is also a cause of headaches. It's a cause of depression, believe it or not. It's also a cause of diffuse musculoskeletal pain. So someone with diffuse body pain from fibromyalgia, you always want to check that test, the vitamin D is in David level. Another thing, endocrine level that one wants to check is the testosterone level. Even for women, I do pain management, and a lot of women take a lot of opioids for chronic pain. And opioids can decrease the testosterone level in both men and women. And low testosterone level is associated with increasing body pain as well as depression and just not feeling yourself, and also making the pain a lot worse. So those are some of the takeaways with that. In terms of epilepsy, again, if patients drinking a lot of alcohol, and if you abruptly stop drinking alcohol, you can have a seizure, withdrawal seizure from that. There are certain medications. A lot of us are anxious in this day and age. If you're taking medications like benzodiazepines for anxiety and you stop it abruptly, one can have a seizure from that also. So one have to be careful with abruptly stopping certain medications. In terms of Alzheimer's disease, again, use it or lose it. You want to form different brain connections and keep your brain active, always learning new things. I mean, I get excited when I learn new things in and out of my field. I think it's just exciting. I love to learn new things. And I learn new things from everyone, from my patients, from kids, from whomever. It's just wonderful. Parkinson's disease, if you start the classic, a lot of people get upset and concerned. They have a little shake, and it's usually an essential tremor from maybe too much caffeine, or maybe just an essential tremor, which is hereditary. But if you have what we call a pill rolling tremor, it's almost like you're rolling, for those of us who are Catholic, rolling rosary beads. That, and it's resting. So it's a resting tremor, and it's what we call a pill rolling tremor. If you have something like that, you want to see the neurologist because that is more suggestive of Parkinson's disease. Or if you notice that your handwriting is getting smaller and smaller, and people are saying, geez, I can't read your handwriting anymore because it's so small, that is something you want to run to the neurologist. It's a telltale sign. You want to run to the neurologist to see if indeed you're starting to have Parkinson's disease. And again, in terms of stroke, if you're having many symptoms, some I'm talking and maybe I didn't make a sense, and my speech was garbled, but then it went away, and then maybe a month or two later, something else happened and it goes away. Those are all signs that you might be having mini strokes, and you want to definitely pay attention to that. And for those of us who are African Americans or anyone who has high blood pressure, you want to definitely make sure and treat that blood pressure and keep it under control, because you can have mini strokes from that, which can then lead to dementia, vascular form of dementia.
So if somebody wanted to get in touch to come and see you, how would they go about doing that, Doctor?
They definitely can. I can give you my office number. My office number is 516 233 2634.
Let's see if we
And
can
I
get
am
that placed into the chat.
at 1991 Marcus Avenue, two levels down in Suite M217 in Lake Success. Some people call it New Hyde Park. And I'm here 5 days a week. And I do neurology and I do pain management. I do a lot of Botox. I do medicinal cannabis. I treat a lot of patients with migraines. And I try to treat the whole human being. As a neurologist, we do a lot of psychiatry and training. And even though I'm not a psychiatrist, given everything that we're going through as a society, I also do a lot of my own psychiatry here with my patients. I listen a lot. I try to give advice when I can, because we all have to look out for each other, especially women. We definitely have to look out for each other.
Absolutely. With the few minutes that are left, I am going to open it up for the audience if they have any questions. And like you said, especially now with what's going on in society and what's going on, with the pandemic and just the world overall, we have to definitely figure out ways to improve our health and also improve our longevity um, for our families as well as for us. Because
And to that point, there's something. The word is bandied about a lot, but it's self care, and you have to do a lot of self care. And it's, believe it or not, it's something I just started doing like maybe a month ago. Started doing self care, and so you really need to take time for yourself. Some of us women, we feel like we have to go 24/7. We have to take care of everything. Our shoulders are very broad, and everything is, we take on all these different activities, and it's okay to say no. It's a word that I really don't know. I'm telling you, that is a word that I really don't know very well, but it's okay to say no. And I'm learning that sometimes it's okay to say no.
so one of the questions that's in the chat, it says, how is COVID-19 affecting young children? So do we see it affecting from any kind of neurological standpoint? And in general, how is it affecting young children?
besides the fact that the kids are very anxious about it, young children have neurologic disease, almost like an encephalitis, which is like an inflammation of the brain, that we were seeing more so with the Delta variant than we see now with the Gamma variant that we have. So when it first back in 2020, we were seeing children with a lot of neurologic problems from the Delta variant of COVID. We're not seeing that as much now with this variant. I have seen young boys with COVID testicles where it affects the testicles, meaning that they get swollen testicles, which is very painful, makes it difficult for them to walk, of course. And so these patients, the kids also usually get tired, and they end up with also sometimes with a lot of respiratory problems, especially if they have a history of asthma. It really settles in their lungs and they have problems like that.
And what should the parents be looking for from a neurological standpoint with COVID-19 effect?
In terms of the COVID neurologic, if the kid is not themselves in terms of the normal behavior, depending on the age of the child. If the child seems to be regressing, if it's like a 2 or 3 year old and now they're regressing, you want to definitely pay attention to that and check in terms of COVID. Again, if the child is having problems in school, concentrating, if the child is now starting to wet their bed because they're now having a lot of anxiety, if the kid is depressed, we've seen a lot of depression also in young children with COVID. I mean, we as adults barely know how to handle this pandemic, let alone younger kids. So anything like that, any change in the child's behavior needs to be addressed immediately.
Do children grow out of febrile seizures, and what medications are good to treat this condition?
Yes, children tend to outgrow febrile seizures. Febrile seizures are usually seen, as I said, usually in kids 18 months and younger. By the time they get to the age of 2, usually they grow out of the febrile seizures. And when they're that young, there are multiple different medications that one can use to treat them. There's phenobarbital, there's topiramate, there are a lot of different medications. But usually 90+% of children outgrow febrile seizures by the age of 2.
One of the things you mentioned earlier as well, while we wait for more questions to come in, is that there can be genetic components to some of the neurological conditions we mentioned earlier, like Alzheimer's and Parkinson's. And there are genes that can be tested for. Can somebody come to a doctor like yourself and get those genetic testing done, or do they need to go to their internist or geneticist? How are they able to get that
They
done?
normally need to go to a geneticist. You can come to someone like a neurologist, though, and there are certain labs like the Mayo Clinic or certain labs that have different panels that one can order to see if you have any kind of genetic basis for it. Certainly, for the neurologic disorders, most neurologists who do general neurology can test for those genes. Of course, a geneticist would be another person. The internist I will not go to test for anything like that. No.
Okay. Another question is, should parents be very particular about children's diets and certain brain conditions?
There should definitely be, definitely so, in terms of later obesity. You should definitely be giving them foods that are rich in omega-3 and antioxidants to help protect the brain from an early age. You definitely, not to talk badly about, football, but I am not a big proponent of kids playing a lot of contact sports where they can get repeated head trauma, because that is problematic. I see a lot of kids who have repeated head trauma from playing football or contact sports, and that is an issue. And if they had like 2 concussions, I tell the parents if it were my child, they will no longer be playing that contact sport. But everybody have to make that decision on their own. But those are some of the things that is very concerning to us neurologists.
Understood. Um, when you think about children early on playing football, starting in middle school, before even high school, like you said, early on. And now there are teams for women, right? And for young girls. If they continue to play it, how would you recommend that they try their best to protect themselves? And should they, besides seeing their regular pediatrician, have annual visits with a neurologist to make sure things are okay?
Yeah, they definitely should. It's difficult. The way how you get injury with playing contact sports is what we call a coup contre coup type of injury. So even if you're wearing a helmet, when you slam, against something and you come to stop after going 60, you go from 60 to zero. The brain inside the skull, it goes back and front, it goes forward and backwards. And there's what we call shearing forces. So it hits up against the front of the skull, it goes back and it goes back and forth. And that is what causes the damage. So even if you have on a helmet, you're protecting the skull from maybe getting a skull fracture, but you're not protecting the brain because the brain is still going to rattle around inside the skull itself. And depending on how much movement you have, you can even get what we call shearing forces where the blood vessels can tear and you can have a bleed in the brain. So, if you have one concussion, depending on how severe it is, and how long the person take to recover. If it is a very severe concussion and the person was unconscious for an hour or two, in my book, that person is not going back to any contact sports. You're done. You're absolutely done. If it was a mild concussion, you were dazed, you were a little bit confused, and things resolving you back to baseline within an hour or so, then I would have you go back cautiously after about 2 to 4 weeks. And but again, repeated head injury, it's no good. It depends on the extent of the concussion, and the more concussions you have, is the longer you'll take to recover until you get to the point where there's a point of no return where the recovery will not exist anymore.
Okay. So we talked about a lot of different topics. I want to thank you so very much for being the guest on my show this evening,
You're so welcome.
and empowering women. We have shared a number of important information with our community and our women. And so we will continue to make strides in improving health. So I want to thank you. And it was a pleasure having you on. I don't see any further questions in the chat again, but I'm going to ask you to please repeat so we can put it into the chat. Your office phone number, please.
516-233-2634.
Okay, let's hope that we can get that up there. And the address?
1991 Marcus Avenue, Suite M, 217 in Lake Success, 11042.
Okay.
I also have an email address, which is my name, gracefordmd@gmail.
Okay.
All one word.
So that is a great way to get in contact. Again, thank you. I know you are making great strides with improving people in our community with their headaches, their pain, and all of their neurological issues.
Thank you so much, Dr. Joan. This was such a pleasure. Thank you so much for the opportunity to speak to you and your guests today.
Thank you very much.
Thanks.
Take care.
All right, stay
Bye.
well. Bye.
You're listening to All About Us Radio. We're live streaming 24/7, playing old school versus new school. Follow us on Facebook, Twitter, Instagram at AAU Media, and visit our website www.aaumedia.com. Call us at 1-833-369-1444, extension 1, and leave us an inspirational message or request. You're listening to All About Us Radio.